Litteraturhuset var arenaen da Erfaringskompetanse og We Shall Overcome inviterte til dialogmøte med titlen En mirakelpille for psyken, og godt over 150 hadde funnet veien. Helsejournalisten Robert Whitaker hadde innledningen med et foredrag der han gjorde et dypdykk helt fra de første studiene når Neuroleptika ble introdusert og frem til i dag.
Thank you for having me here. It's a real pleasure. It's my first time in Norway, so it's really great to be here. I will try to speak as clearly as possible and so everyone can understand. I wish I could speak Norwegian, but I don't speak a word. So just a little bit of background, how I came to be here. So I'm a journalist by background. I've been writing about medicine and science for a long, long time, about 25 years for newspapers and magazines. I was briefly director of publications at Harvard Medical School, and while I was there, they kept talking about the importance of evidence-based medicine, and that's one of the things we'll talk about tonight, evidence-based medicine. And how I got involved in writing about psychiatry was a little bit backdoor. In 1998, I was doing a series for the Boston Globe on abuses of psychiatric patients in research settings, and I was just going to do that one series. But while I was doing that series, I came upon some studies done by the World Health Organization on outcomes for schizophrenia patients that really perplexed me and that really launched me on this long journey about writing about psychiatry. And here were the studies. The World Health Organization, they did one study of 2 years in length, one study of 5 years in length, in which they compared outcomes for people diagnosed with schizophrenia in the US and 6 other developed countries, with outcomes in 3, quote, developing countries. And the developing countries were India, Nigeria, and Colombia. And each time, they found that outcomes were much better in the poor countries of the world, specifically in India and Nigeria. And they concluded, and this was the line that launched me on this long path to writing about psychiatry. They concluded, the World Health Organization, that living in a developed country is a strong predictor that you won't have a good outcome if you're diagnosed with schizophrenia. And I wanted to know, why would that be? Because we're so proud in our Western societies about advances in medicine. And my understanding at this time, by the way, was that we were discovering the biological causes of schizophrenia. We had drugs that fixed those causes, and we were making these great advances in care. And yet suddenly I was confronted with 2 studies that said something very different. And then my confusion really deepened. Because after the first study, the World Health Organization investigators hypothesized that maybe the reason for the better outcomes in the poor countries was that their patients there were more medication compliant. They took their antipsychotics more regularly. Now, that makes sense as a hypothesis if you believe that the medications are essential treatment for schizophrenia. And by the way, I had, as part of that series for the Boston Globe, we had written how it was unethical to ever do a study in which you withdrew antipsychotic medication from patients because we said these fixed chemical imbalances in the brain, they're like insulin for diabetes. And then what did the World Health Organization investigators find? They found that they used the medications quite differently in the poor countries. They used them acutely, but they kept very few people on the drugs long term. In fact, only 16% of the patients in the poor countries were maintained regularly on antipsychotics. So my point is here, this whole journey for me began when I was confronted with evidence that was contrary to what I knew to be true, which was that the medications were absolutely essential. And basically, I wrote that first book that you mentioned, Mad in America, to try to explore why do patients in the rich countries of the world have worse outcomes than in Nigeria, than in rural India. It just didn't make sense, and it was a failure that I thought our societies should address. So I wrote that book, Mad in America, which was a history of the treatment of the severely mentally ill. And that book was controversial. And after that book, I told my agent, I'm not writing about psychiatry ever again. I'm done. It's too controversial. anyway, what happened was I then wrote another couple books, but people kept asking me, well, what about depression? Where are all the bipolar patients coming from? And we're now medicating children. In the United States, we've been doing it for about 20 years. You're starting to do it now in Norway as well. It took us a while in the United States to export this form of care to you all, but we're doing it quite successfully, I think. And I wanted to look at these questions. Is this working? Is it working for us as a society to be diagnosing so many people and to be using medications on such a grand scale? So I wrote this book called Anatomy of an Epidemic, which actually came out about 3 years ago. And I've been on the road ever since, and I think here's why. What I tried to do in this book was ask a new question. And the question was this: how do these medications affect people over the long term? Which is a very different question. Drugs get approved for use because they're shown to be effective over the short term. They knock down, quote, the target symptom of a disorder better than placebo for like 6 weeks. But I wanted to ask a different question. What happens to people after 3 years, 5 years, 7 years? And are we really improving people's lives over that long term? And I was looking also in this book at a larger question than just of symptom management. So the way drugs get approved is, again, they knock down a target symptom better than placebo, but that doesn't tell you how people are functioning. Are they employed? Are they socializing? Are they enjoying life? So in this book, I wanted to look at that larger question about functional outcomes. And as a start, as to raise this question, I looked at this data. In 1987 is when, in the United States, we got a drug called Prozac. I think you call it Prozac in Norway as well, right? And this was the first of the second-generation antidepressants. And there's just, these new antidepressants are said to be so much better than the old ones. And then in a few years, we got new antipsychotics. In the United States, they're called atypical antipsychotics. And these are drugs like Zyprexa and Risperdal and Seroquel. I don't know what the names are here in Norway. Same. And these are said to be so much better than those old drugs like Haldol, et cetera. So this is a story of progress, right? You get new drugs better than the first ones. So as a first step of assessing whether the use of these new drugs is so helpful for us as a society, I just looked at the number of people going on disability in the United States due to mental illness. And the thought is, if you get better drugs that are effective, if anything, the disability rate should stay the same or go down, right? Because you have a better way to manage those problems. Instead, the exact opposite occurred. In 1987, we had 1.25 million people in the United States on disability due to mental illness. That's why they were declared eligible. We're now around 5 million people. So that's a fourfold increase. And so you start to see a question arise. Why, as we embrace this medical model and the widespread use of psychiatric drugs, are disability rates going up in the United States? Now, since that time, I've been traveling around a lot to other countries, and every country that has adopted widespread use of these drugs, well, I've looked at the disability rates, you're seeing the same thing. You see disability rates soaring. And so that raises a question for us. Why is this? Now, in the United States, for example, we spent $800 million on psychiatric drugs in 1987. Any guess what we spent in 2007 as a country? $40 billion. So that's a 50-fold increase in spending on psychiatric drugs. And yet, as we did so, the burden of, quote, the burden of mental illness in our society is going up and up and up. And once I started with that data, then I wanted to look at this. Okay, so let's look at what science has to tell us about how these medications shape long-term outcomes. And in that book, I look at that as the case for antipsychotics and schizophrenia. I look at it for antidepressants and depression. And I also look at what's happening to bipolar disorder, where are all the bipolar patients coming from, and then also what's happening to children. Now, what I'm going to do tonight is sort of to go over the data for antipsychotics. I don't have time to go through all of them, but we'll pull out some common themes that you see actually with all these medications. Now, one of the reasons that antipsychotics are a good class of medications to focus on is if there's any class of medications that should have a positive risk-benefit, in other words, where the benefit should be clear, it should be antipsychotics. These drugs are seen as at the heart of the psychopharmacological revolution. It's what supposedly made it possible to empty state hospitals or to the hospitals. And they're also the best studied class of drugs. So we'll see more information about antipsychotics than any of the other class of drugs. And so that's why we're going to go through them tonight. I'm going to try to do this pretty fast. I'm going to skip some slides, but if I'm speaking too quickly, just raise your hand and I'll slow down, okay? This is just going back to one of the things that we have to recognize is there's a story out there in which the efficacy of antipsychotics is unchallenged. And you can see it, by the way, in some of, in essence, of your laws, of your regulations, which basically insist sometimes on the use of antipsychotics. And there's a lot of pressure for people to stay on the drugs as well. Anyway, there's a book written by Edward Shorter. He's a famous historian at the University of Toronto. And he says this about antipsychotics. The introduction of chlorpromazine into asylum medicine in 1955 initiated a revolution in psychiatry comparable to the introduction of penicillin in general medicine. Now, there have been few things arrive in medicine as important as the antibiotics. The antibiotics changed modern life. So if this is true, this is a story of a great advance in care. And this is the common wisdom around antipsychotics. Now, the second thing, as a journalist, what I need to do, and remember I come at this as a journalist, not as a doctor, all right, is now I need to see what is the evidence base for the use of antipsychotics. Did you hear this term often in Norway about we're going to have evidence-based medicine? Okay, and the idea behind evidence-based medicine is this. It's actually possible for doctors, if they just look at their clinical experience, to end up deluded about their merits of their therapies. And so you want a scientific reason or evidence showing that what you're doing is correct and helpful, all right? So if you look at the evidence base for antipsychotic, it consists of two parts. One, going back into the 1950s and early 1960s, they had people come into emergency rooms, and they were either they were randomized, in other words, put into either a group where it's treated with antipsychotic, or a drug just placebo, in other words, no drug. And the group that was given drug at the end of 6 weeks generally was much better. They had a diminishment of their psychotic symptoms, okay? So that's evidence the drugs work over the short term, those randomized studies. Now, the next thing for doctors had to ask themselves, going back into the 1960s, is, well, how long should we keep our psychotic patients on these drugs? And they ran studies designed like this. They took that group of people who had responded well to antipsychotics, in other words, their psychotic symptoms had abated, and they either abruptly took them off the drug or they maintained them on the drug, and with great regularity, those taken off the drug relapsed at a higher rate, meaning that the psychotic symptoms came back, okay? And they often were re-hospitalized. So what did doctors see? They said, see, if you stay on the drug, it helps lower the risk of relapse. And that becomes the rationale for long-term use, okay? And that still today is the rationale for long-term use. It's studies where you abruptly, or where you have withdrawn the drug. So my next question is this: is there anything missing from that evidence base as for a rationale for long-term use really for everybody? And you see that there are two flaws with the evidence base. One is this: imagine we run a study, people come into the hospital, half are treated with psychosocial care and no drug, the other half are treated with drug, and now instead of following them for 6 weeks, we follow them for 2 years, 5 years. And we look at how this group never exposed to drug is doing on such items as employment, cognitive function, social interaction. The problem is the relapse studies don't tell us what might have happened if we never put people on drug, right? In terms of functioning. What the relapse studies tell us is once you go on antipsychotic, don't come off abruptly. Very bad idea. But it doesn't tell us about how those people are functioning over the long term. So that's one of the missing things in the evidence base. The other thing that's a problem is the design of the studies themselves. Almost all of these studies where they withdrew the medication was abruptly withdrawn. And now we know that abrupt withdrawal increases the risk that symptoms will return. So a lot of what you're seeing here when people relapse when coming off is a drug-related effect. It's not what you're seeing in the natural course of the disorder. So that's the limitation of the evidence base that you in Norway and we in the United States use to justify long-term use. It doesn't show that we're helping people over the long term. Now, in 2002, a psychiatrist at the University of Montreal addressed this very question. He said, we've been using these drugs for 50 years. Do we really have good evidence that we're improving people's lives over the long term? And you'll see what he says here. He says, I've looked at the research literature. There is no compelling evidence on the matter when long term is considered. In other words, there's a lack in the evidence base that we're really helping people. And then if you look at this second quote, all of you here tonight, in essence, are taking the risk that he's talking about. He says this, if we wish to base psychiatry on evidence-based medicine, we run a genuine risk in taking a close look at what has long been considered fact. And in essence, that's the risk you're taking here tonight. Because the understanding, of course, is that antipsychotics are absolutely essential and basically for everyone so diagnosed. But maybe we're going to find a different story in the literature. Now, one caveat here. My interest is exploring this literature from a big picture point of view. In other words, how does society respond to people who, quote, have psychotic symptoms? It's not meant to be medical advice. So if anybody's taking antipsychotics, no one should take what you now hear in the next 30 minutes and use it as a decision for what you personally should do. This is not a medical advice talk. Is that clear? It's just looking at a big picture. So you're a journalist now, and now you just saw that Emanuel Stipp said, we have no evidence showing that the drugs are improving long-term outcomes. But now what I'm going to try to do as a journalist is I'm going to try to find out, well, what is the evidence? What evidence is out there in which they studied long-term outcomes, and what story does it tell? So now going forward, we're going to trace this back for 50 years. Now, in the early 1960s, the National Institute of Mental Health ran a trial designed like this. People came into an emergency room. They were either given drug or they were given placebo. At the end of 6 weeks, the drug-treated patients were doing better. And that's a trial still cited as a reason for using the medications. But many placebo patients got better. Then they were discharged into the community, and they're just followed up for a course of a year. And what they noticed at the end of 1 year was something odd. The medicated patients actually had higher rehospitalization rates. So at this very early moment of the research literature is the vaguest hint of a paradox in which you see that drugs that are effective over the short term, could they be increasing the chronicity of the disorder over the long term? Okay, it shows up. Next, there was what's called a retrospective study done. And a retrospective study is one where they compared outcomes, 5-year outcomes for patients treated in 1947. That's before the first antipsychotic arrives. So these are people treated without drug. And now they're going to compare 5-year outcomes for a similar group of patients treated in 1967 with the drug. You see the comparison? They're going to say, are our outcomes today in 67 better than they were in 1947? And what they found was this. They found that actually there was a little bit higher rehospitalization rate in the 67 cohort, and even much more important was the difference in functional outcomes. So they noticed in the 1947 cohort, 76% were successfully living in the community at the end of 5 years. Now they're noticing that people are much more socially dependent, on welfare, unable to work. All right, from this retrospective study. So they're actually seeing a decrease in outcomes in this study. And here's what this researcher concluded. I don't know if you can all read this. He says, watch this. Rather unexpectedly, these data suggest that psychotropic drugs may not be indispensable. Their extended use in aftercare may prolong the social dependency of many discharged patients. So you see a worry arise here, right? Now, I'm going to skip a little bit of the slides just because of the time pressure. But then in the 1970s, the National Institute of Mental Health conducted 3 trials to revisit this question about the merits of antipsychotics as a treatment for psychosis/schizophrenia. And what was different about these 3 studies is they were not just 6-week studies. One was 1 year, one was 2 years, one was 3 years. And the design was basically this. Either you would have some people treated conventionally with drugs, and in the experimental arm, they'd be treated with a lot of psychosocial care and either no drugs or a selective use model where they would try to minimize use of drugs, okay? And in each time, the experimental arm did better. That was one finding. The second finding was every time there would be a significant percentage of patients, with first episode patients, who in fact would get better without drug. And at the end of, say, 2 and 3 years, it would be that subset of patients who was able to recover without going on drug that would have the best outcomes, okay? So because of these studies in the 1970s, I'm just going to go a little faster here. It raises a really profound question, and this question is raised by William Carpenter, who's still a big figure in American psychiatry. And here's the question he says to himself. We have research that shows the drugs work over the short term. We also have research that's showing when you come off the drug, you relapse at a high rate. But now he's got these 3 other studies which showed that if you never put people on the drugs to begin with, you might get lower relapse rates. So it's a paradox, and that's what he's summing up here. There is no question that once patients are placed on medication, they are less vulnerable to relapse if maintained on neuroleptics. Neuroleptics are antipsychotics. That's the withdrawal studies. But what if these patients had never been treated with drugs to begin with? We raise the possibility that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. Now, this is the late 1970s. Now, the reason this is so profound as a worry that arises within the halls of the National Institute of Mental Health. The National Institute of Mental Health is our agency for investigating psychiatric matters, okay? So this is the core of American medicine. He's not talking about adverse events here. He's worried that the drugs are inducing some biological change that actually makes people more biologically vulnerable to psychosis, the very thing you're trying to treat, okay? And by the way, this worry is now actually surfacing again for all classes of drugs, including the antidepressants. And it's surfacing around a phrase called oppositional tolerance, that the drugs induce something called oppositional tolerance, and I'll show that. But what I'm saying is there's a larger theme here that's arising within medicine, and maybe we can talk about this. So after Carpenter raised this issue, that could these drugs be making people more biologically vulnerable to psychosis, 2 researchers from McGill University stepped forward with an explanation for what they thought was going wrong. And here's the explanation. And I hope I don't lose you here. It's a little bit complicated scientifically. So how do neurons communicate in the brain? You have what's called a presynaptic neuron that releases a molecule, a chemical messenger, we call a neurotransmitter, into the tiny gap between neurons, which is called the synaptic cleft. And that molecule then binds with receptors on the receiving neuron, which we call the postsynaptic neuron. And that's just a graphic illustrating how neurons communicate in the brain. You see that? You have one neuron releasing a molecule, binds with receptors on the surface of the second one, and that's how messages get passed, okay? Now, what researchers came to understand in the 1970s was that antipsychotics, the way they work is they block those receptors, okay? They block dopamine receptors. They sit on those receptors, and because they block it, the message can't get through, okay? So you're thwarting dopamine transmission in the brain. Does that make sense? Okay, you're sitting on those receptors and you're blocking it. You're dampening down dopamine transmission in the brain. But what was coming clear is the brain, being this extraordinarily, adaptive organ, now tries to compensate for the presence of the drug. And think about this. The drug, an antipsychotic, is acting as a blockade, as a brake on dopamine transmission. So what does your brain do? It puts down the accelerator. It's trying to compensate for the presence of the drug. Now, the way it tries to compensate is in one of two ways. The presynaptic neuron actually puts out more dopamine than normal for a while. That compensatory mechanism seems to burn out after some period of time. But then the receiving neuron, that postsynaptic neuron, increases its density, its number of receptors for dopamine, okay? And you see why it's doing that? Because you're blocking some, that's like a blockade, so your brain says, I better make some new ones to try to compensate for the fact that you're thwarting this normal transmission of messages. So this is a drawing not by me, but that appears in some medical texts to show what happens. And you'll see what they're showing is that once you go on this drug, you get an increase in receptors, okay? And what researchers were saying is the brain is now super sensitive to dopamine, and now it in fact is more biologically vulnerable to psychosis. That was the claim being made in the 70s. Now think about this just for a second. You go on the drug, it acts as a brake. Your brain puts down the accelerator, okay? Now take away the drug, what do you got? The accelerator down, right? Do you see why you might have an excess risk of relapse once you go on? Because the brain has changed, it's adapted to the presence of the drug. And so this is going to expose you to a lot of risk of relapse when you come off, especially abruptly. Does that make sense? The other problem is this, though, that they began to worry about. Is this going to be good for that dopamine system long term, to have the brake on and the accelerator down? Is that really going to lead to like a good functioning of that system? And they began to worry that in fact that the system might become a bit dysfunctional. And there's a dopaminergic tract that goes to the basal ganglia. That's an area of the brain that controls motor movements. And they were noticing that some people on antipsychotics long-term were developing something called tardive dyskinesia, which is repetitious movements, which is a sign that the basal ganglia is becoming dysfunctional. So these researchers said, you know, you also have a dopamine tract that goes to the limbic system. If that becomes dysfunctional in the same way, maybe you're going to become chronically psychotic. And they're going to call it tardive psychosis. And they looked at their patients who had been on antipsychotics for 10 years, and they concluded that 30% now had chronic psychotic symptoms related to this change in the brain. And I don't know if you can read this. Oh, you can't read it because I haven't done it. So here's what they're saying is the consequences, right? An implication. Neuroleptics can produce a dopamine supersensitivity that leads to both dyskinetic and psychotic symptoms. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. They're saying we're worried that we're making people more biologically vulnerable to psychosis. This is the study I just talked about. And they concluded that among their patients, 30% who had been on the drugs on average of 10 years showed signs of tardive psychosis, when the psychosis was becoming more permanent. And you'll see, when this happens, they wrote, the illness appears worse than ever before. New schizophrenic symptoms of greater severity will appear. Now, this is the worry that arises in the early 1980s. You can see it's called dopamine supersensitivity. And then you can see it's a big worry, right? And then it's pushed aside. Basically, there's some very famous American researchers that said, we're not going to worry about this anymore. Stop talking about it. And you do see it get pushed aside. So one of the things we're going to want to look at now in the next 15 minutes is whether research since that time has given us any reason to continue to worry about this, Or is it, in fact, a worry that we can safely say is not a worry? Okay? So we'll go forward. I'll skip through I just told you about the WHO studies. Remember, the WHO studies did find that outcomes were better in the countries where they were using medications more differently. Now, in other words, in the WHO studies, there were better outcomes in the countries that weren't keeping most of their patients on long term. Now, this is a little bit of this is not going to dopamine supersensitivity. This is a new worry that, frankly, has arisen in the last 15, 20 years as a result of new MRI technology. Do you call it MRIs? Yeah, for measuring brain volumes, et cetera. Now, this information, I think, can be really upsetting to people who use these medications. Sometimes, to be honest, I hesitate even to show this data. I think it is concerning, and I don't mean to be upsetting anybody, but on the other hand, I do think if things are being found, we need to make it part of the discussion, okay? Anyway, if you give either the older antipsychotics or the newer antipsychotics to monkeys, their brains will shrink. They did this to macaque monkeys. And this is in dosages that are appropriate for the monkey's weight, okay? And you'll see this finding here. What happened is they gave them to two groups of monkeys. One group got the drug, the other group did not. And then after 24 months, basically, they sacrificed the monkeys, and then they weighed their brains. And they found that those that had been exposed to antipsychotics had reduced brain volumes, okay? And you can see this. The difference in brain weights and brain volumes were observed across all major brain regions, but appeared most robust in the frontal and parietal regions. Now, in the United States, there has been one long-running MRI study, goes back to the early 1990s. It's a large study. 500 schizophrenia patients were recruited into it, which in schizophrenia standards is a large study. It was done by Nancy Andreasen. Nancy Andreasen is the former editor of the American Journal of Psychiatry. She's very much a biological psychiatrist. And when she started this MRI study, she had this hypothesis. Schizophrenia is a neurodegenerative disease characterized by brain volume loss over time. So she was expecting to find brain shrinkage over time, but she would think it was due to the disease, okay? That's her hypothesis. And you'll see that in 2003, that's what she found. She reported that, this was about 10 years after she began this study, she reported that schizophrenia was a progressive neurodevelopmental disorder characterized by progressive reduction in frontal white matter volume. When she publishes this, she's saying it's due to the disease, okay, not the drug. But she has a problem. Oh, then, still as to a disease, she reports, as you get this brain shrinkage, you get an increase in negative symptoms. That's that emotional disengagement. You get an increase in functional impairment, and you get an increase in cognitive impairment. So she is putting together a picture of a deteriorating disease course, okay? That's what she's doing here. But she has a problem. The monkeys did not have schizophrenia. So is it due to the drug or the disease? Or maybe both. And so she looked at this, and what she found, in fact, she concluded it's certainly drug-related and even dose-related. The more dose, et cetera. So what did she report in 2011? Use of the old neuroleptics, that's chlorpromazine and Haldol, the newer atypical drugs and clozapine, quote, were all associated with smaller brain tissue volumes, with decreases in both white and gray matter. The severity of illness and substance abuse had minimal or no effect on brain volumes. So what she found, in fact, that there's some drug-related brain shrinkage as well. Now, this is what she told the New York Times, if you can see this. What do these drugs do? They block basal ganglia activity. That's by blocking those dopamine receptors. The prefrontal cortex doesn't get the input it needs and is being shut down by drugs. That reduces psychotic symptoms. It also causes the prefrontal cortex to slowly atrophy. Atrophy is a word for, diminish. This is a new study that just came in, 43 brain imaging studies of first episode psychosis, and the European researchers determined that the loss of gray matter volume was significantly more severe in medicated patients. So can try to finish this up soon. Here's why this is upsetting. Think about this. You have an outside agent, right? That's the drug. You give it to people, and now you can measure a decrease in brain volumes over time. And the best evidence is as that decrease happens, you're getting more emotional disengagement, more functional impairment, and more cognitive impairment. And that is basically a story that's apart from the dopamine supersensitivity. That's sort of a story of an iatrogenic treatment. Do you know the word iatrogenic in Norway? Iatrogenic means where the treatment itself is causing harm, okay? So that's sort of that model. Outside agent comes in, causes a measurable change in brain volumes, and that brain volumes is associated with these problems. Anyway, this is a new worry that's out there, and I know it's concerning for anybody on the medications. I feel bad about that, but I also believe as a journalist we should try to make all this known and we can discuss its implications. All right, now we're going to go to two last studies. In a way, we have dueling histories out there, okay? We have the common wisdom, which is that the antipsychotics arrived in asylum medicine in 1955, and they kicked off this great revolution in care, this great advance in care, the psychopharmacological revolution. And that's the story that is believed by society as a whole, by medicine as a whole, and it's a story I believed when I began this whole long process of reporting on it. But I've told you the bare bones of a different story tonight, of that it's really a paradoxical story of drugs that help over the short term may be worsening outcomes in the aggregate overall in the long term. This does not mean that nobody benefits. It just means we're talking about what happens to people in the aggregate. Now, the thing about science is it should be predictive. In other words, if you have and we're going to look now at a long-term study. If the conventional wisdom is true, then those who are medication compliant should have better outcomes, right? If the story I told you true is predictive tonight, in other words, the science we just reviewed, we may see something very different, right? If the story I told is predictive, we may see more psychotic symptoms in the medicated patients long-term and less functional sort of capability, all right? Now, this is the only study I know of in the literature that's a prospective study, meaning you start following people from the initial moment of treatment and you follow them for 20 years. So this was done by Martin Harrow at the University of Illinois. It was funded by the National Institute of Mental Health. It began in the late 1970s and 1980s. It's what's called a naturalistic study. There's no randomization to either this type of treatment or another treatment. Everybody is treated with drugs in the hospital, then they're discharged, and he's just going to follow them for the next 20 years. He's going to follow them at 2 years, 4.5 years, 7.5 years, 10, 15, and 20. And when he does his follow-up interviews, he's going to look at, are they using antipsychotics? Are they psychotic? Are they in recovery? How anxious are they? What's their cognitive function? And he's just going to see how they're doing, okay? What's nice about this, he enrolled 200 patients from 2 area hospitals, one private, one public, so it's a nice mix of poor and not so poor people. And the biggest thing that's important is they're young. About half of the people, it's their first episode of psychosis. So he's getting people right from basically the beginning of initial diagnosis, okay? He enrolled 200 patients. At 15 years, he still had 145 patients in his study. That's really good. And you'll see the diagnosis. 61 had a diagnosis of schizophrenia, 81 with milder psychosis. Here's the outcomes. We'll go through this fast. Anxiety symptoms. By the way, by the end of year 2, 25 of the 64 patients had gotten off antipsychotic medications. They had taken themselves off. It's not the doctors took them off, they took themselves off. This would not happen today. There was more possibility of going off in the 1980s than there is today. It was considered more tolerable. Look what happens here. At year 2, the percentage of people suffering high anxiety is about the same. You see what happens to the group that comes off? There's a lot of reduction in anxiety. The relapse studies don't show this healing possibility. The relapse studies tell you don't come off your drugs abruptly. But this is showing you a different perspective. It's really showing you a healing process that's taking place later on after diagnosis, okay? And we don't see that in those other studies. But these are big differences. And there's also the worry, why are the people on the drugs actually becoming more anxious? So there's a real worry in that one. This is cognitive function. Remember we talked about, unfortunately, the MRI studies. So if those MRI studies are correct, you would expect to see better cognitive function in the unmedicated group. You do here at every follow-up, okay? Now, how about psychotic symptoms? If dopamine supersensitivity is really a problem, if it's real, you should see those who remain on their drugs much more psychotic later in the course. It's exactly what he found. You'll see that at the 10-year follow-up, only 23% of those off drugs were still having psychotic symptoms versus 79% of those on drugs. Now, this is consistent with the dopamine supersensitivity worry. And Martin Harrow, the researcher, is now re-raising this thing to explain his own data, that we may have a real problem here, because these are the target symptoms, okay? Recovery rates. Now, he used a very robust definition of recovery. To be in recovery, you had to be employed at least 50% of the time, or you had to be in school. So this is not just symptom reduction. This is you had to function well as well. You'll see at the end of 2 years, there's not that much difference, right? The recovery rate for those off meds is 20% versus roughly 6 or 7. Again, the difference happens between year 2 and 4.5. That's when the outcomes diverge, such that by the end of 4.5 years, the recovery rate for those off medication is 40% versus 5% for those on medication. And that stays that way throughout the study. This is just global adjustment. He has a scale for measuring that. You'll see again at year 2, not much difference. It's between year 2 and 4.5. This is the only place in the research literature you see this perspective. It doesn't show up anywhere else. Well, it's going to show up in a brand new study. So Harrow has three classes of outcomes: recovered, so-so, uniformly poor. You'll see that for the on-antipsychotic group, it's 5% recovered at the end of 15 years, 46% so-so, 49% uniformly poor. The off-medication group, it's 40% recovered, 44% fair, 16% uniformly poor. So it's not just that there's more recovery in the off-medication group. There's also fewer people in the uniformly poor category. Now, here is his conclusion from the only long-term prospective study we have that he gave at the 2008 meeting of the American Psychiatric Association. And I'll ask what I asked at a morning meeting. Can you all read this? He says, I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global functioning than those on antipsychotics. Have you been told that in Norway? No. This was not reported in the United States either. No newspaper, no magazine. It's because it wasn't publicized. And the reason I think it wasn't publicized is this so belied a whole form of care that also has some commercial funding behind it as well, because this really challenges that. This is just the milder psychotic patients. Again, you'll see that those got off did better. Now, please look at this chart. So he has 4 groups, right? He's got schizophrenia on meds, schizophrenia off. He has milder disorders on meds, milder disorders off. Here's the key. This group had a milder diagnosis at the beginning, right? But those who stayed on meds had worse outcomes than the schizophrenia group that got off. So the point is, why do milder patients who stay on and are medication compliant end up worse than those with a worse diagnosis beginning who got off medications? This data is precisely the reverse of what you'd expect if the medications on the whole are helpful. You should see the medicated patients doing better. You should really see the best should be milder disorders on meds, and then it should be schizophrenia on meds should be the best. And best, by the way, on this chart is towards the bottom, okay? Now, there could be many interpretations of this data, okay? My plea as a reporter, as a journalist, is let's just make it known to society and make it part of our societal discussion. And actually, frankly, a lot of the psychiatric community doesn't even know this data so well. And all I'm saying, if we're going to do well by people, we need to have an honest discussion of what science is telling us. And this data got buried. Now, he raises this question in a paper that was just published, and it goes to this paradox we're talking about here. We have medications that work over the short term. We see that when people come off the medications, they do poorly so often, okay? And that reinforces the idea people have to be on the medications. And yet when we shift our perspective to long term, are we really helping people thrive long term? We're not seeing an improvement in outcomes in the aggregate. And it doesn't mean nobody's doing well, it just means in the aggregate. So what does Martin Harrow, what did he write a couple months ago? He says, how unique among medical treatments is it that the apparent efficacy of antipsychotics could diminish over time or become ineffective or harmful? There are many examples of other medications of similar long-term effects, with this often occurring as the body readjusts biologically to the medications. He's talking there about the dopamine supersensitivity adjustment, okay? But what I want you to see here, this appeared in the Schizophrenia Bulletin. This is actually a mainstream bulletin. So I come here before you and you might think, who is this crank talking like this? What I'm trying to say here is this is now entering mainstream American psychiatry, this worry, all right? It's not just this crank raising it. It's now being seen as a really legitimate worry. We have brand new study coming out of the Netherlands. It was done this way. You had people over 25, first episode, hospitalized. They stable on medications. And now they're going to be randomized either to, randomized means, divided just by chance, into a group that's going to be, you're going to try to get them down to the lowest possible dose or either all the way off compared to standard drug use, okay? It's a randomized study. And he ends up with 103 patients. Now notice this. If you look at relapse, at the end of 2 years, those randomized to the drug withdrawal group had higher relapse rates. So if we don't want to look at this, you just want to look at this part as the evidence base, this supports that you keep people on the medications. You see that? Because this relapse rate is higher. But then he followed them for another 5 years. And what he found is this group tended to become stable. And there wasn't so much relapse from year 2 to 5. And by the end of 5 years, there was actually more, 7 years, more relapse in the treated as usual group. Now, this is not very significantly different, okay? This is not actually that important. But it's important in the sense that this stabilizes, okay? That's what's important. Here's the key finding. It's functionality. So recovery, which he's looking at employment, that sort of thing. You'll see that the recovery rate was twice as high for those randomized to this drug reduction group. Okay, so again, he was seeing the same thing, better functioning. And he also did this. The way this was done, people were randomized to a drug reduction, but then it becomes naturalistic, and some people actually sort of went back on drug, that sort of thing. And actually, some of those randomized to standard care got off drug. So then he grouped his patients just at basically those who got all the way off, or very, very low doses versus standard care. And here's his outcomes. You'll see symptom remission, better for the low dose or discontinued group. Functional remission. First of all, that's really good functional remission. 56% are functioning well. You see that? There's a lot of recovery there. But it's much more than the standard, those on medications, and you'll see full recovery as well. So, and I'm almost done here. What does he conclude here? This just came out in July, all right? This is sort of really fresh research. One, he does conclude that antipsychotics may worsen functional outcomes. I'll read this in case people can't. Antipsychotic postsynaptic blockade of the dopamine signaling system, particularly of the mesocortical and mesolimbic tracts, not only might prevent and redress psychotic derangements, but also might compromise important mental functions, such as alertness, curiosity, drive, and activity levels, and aspects of executive functional capacity to some extent. So you see there's a worry there, right? And then he writes this. And this goes to this question of how do we know what we do? And he's saying what we've been looking at has been flawed. He's saying that evidence base has been flawed. He says the results of this study lead to the following conclusions. Schizophrenia treatment strategy trials should include recovery or functional remission rates as their primary outcome, not symptom reduction, and should also include long-term follow-up for more than 2 years, even up to 7 years or longer. In the present study, short-term drawbacks, such as higher relapse rates, were leveled out in the long term, and benefits that were not evident in short-term evaluation, such as functional gains, only appeared in long-term monitoring. So what you're hearing tonight in this data is, should we rethink how we assess the merits of these medications? We've been looking so much about symptom reduction, but maybe we should look about how do people function on them long term. Summary, just 3 or 4 more slides. Here's the problems that I think that show up in the research literature. You have the supersensitive psychosis, this worry you're making people more psychotic over the long term. And by the way, I want to emphasize, I think the drugs have a place. The question is, what place? I think we do have to really confront and research this brain shrinkage. And then, of course, you have the adverse events. These are sort of the problems I see with these drugs. Again, just so you don't think you're hearing this from a crank, now, I published this book in 2010, and we've got new data since then, and we've also got new editorials saying we need to rethink these drugs. This is from the British Journal of Psychiatry. The people who wrote this editorial have associations with the National Institute of Clinical Excellence in Britain, which is their agency for setting standards of care. Okay, so this is from mainstream British care. You'll see it is time to reappraise the assumption that antipsychotics must always be the first line of treatment for people with psychosis. This is not a wild cry from the distant outback, but a considered opinion by influential researchers. There is an increasing body of evidence that the adverse effects of antipsychotic treatment are, to put it simply, not worth the candle. Does that translate into, it means they're just, yeah. This is JAMA Psychiatry. This used to be the Archives of General Psychiatry. Again, another mainstream journal. This was an editorial published just this past month to accompany that Wonderink finding. What does he say? In moving to a more personalized or stratified medicine, we first need to identify the very small number of patients who may be able to recover from first episode psychosis with intensive psychosocial interventions alone. Now, actually, I think it's more than a small number. It's not everybody, but we need to know what that might be. Then he said, for everyone else, we need to determine which medication, for how long, in what minimal dose, and what range of intensive psychological interventions will be needed to help them get well, stay well, and lead fulfilling and productive lives. These factors have rarely been the goal in the real world of clinical psychiatry, something we must finally address now that we are armed with stronger evidence. And look at the last 3 words: to counter poor practice. And that's what we're talking about here, is changing protocols along with the evidence. There's one group that I know of in the developed world that's using antipsychotics in a selective way around 2 principles: not putting people on antipsychotics right away, and then if they use them, seeing who can get off. So the way they do it in northern Finland is this: they don't put people on antipsychotics right away. They try to get them through the first episode with psychosocial care and some limited use of benzodiazepines. But if people aren't getting better, then they do use antipsychotics. Makes sense. And then they figure out who needs them to stay on them long term and who can go off. It's a selective use model. Okay, it's figuring out for whom and for how long. They began this in 1992, and they now have by far the best reported outcomes in the Western world. At the end of 5 years, 80% of their first episode psychotic patients are either working or back in school. Only 20% have gone on to long-term disability. I can guarantee it, you're not getting those outcomes in Norway for your first episode psychotic patients. And look at the medication use. Only 2/3 of their patients have never been exposed to antipsychotics after 5 years. There's another 13% that were on for a period of time, and then 20% on them regularly. What I like about this study, this is not an anti-medication model. This is a best use model, figuring out for whom and for how long and when. It's just a different model than one size fits all. Last slide. Here's one of the lead researchers, Jaakko Seikkala. He says, on the importance of using neuroleptics in this selective fashion, I am confident of this idea. There are patients who may be living in a quite peculiar way, and they may have psychotic ideas, but they still can hang on to an active life. But if they are medicated because of the sedative action of the drugs, they lose this grip on life, and that is so important. They become passive, and they no longer take care of themselves. So that's the story around antipsychotics. I hope what you saw in this very brief thing, that at least it doesn't seem to you that it's arising out of an anti-medication ideology. I don't have an anti-medication ideology. What I was trained in was let's follow the evidence. And I think the evidence is telling us we need to rethink these use of drugs if we want to be concerned about how people fare over the long term. And I will say this, Norway is a small country. You have a fair amount of money. If you were to develop new protocols, you could be a real leader for rethinking your use of these drugs. So, thank you.